I'm Chris Christodoulou. I'm a neuropsychologist at the Center for Excellence in Alzheimer's Disease at Stony Brook. And today I want to give you a little talk about Alzheimer's disease. And this will be the COVID-19 edition. This is a little similar, or quite similar actually, to a talk that I gave earlier this year. And so if you've already seen that talk, maybe some of this will be familiar. But let's see how it goes. And I'm happy to take your questions. You can type your questions into the chat box, or you can raise your hand and Brooke will help me to identify those questions later, okay? So here we go. As I mentioned, I'm from the Center of Excellence for Alzheimer's Disease. We're at Stony Brook University, and we're one of 10 centers throughout the state that's supported in part by the New York State Department of Health. And our goal is to expand knowledge about Alzheimer's disease and related dementias, and to act as a resource for Nassau and Suffolk County healthcare providers, and to improve access to screening, diagnosis, and treatment for patients and their families. So dementia globally and locally is a huge problem. It's a huge issue. It's been called the greatest global healthcare challenge of the 21st century. It's affecting more than 47 million people throughout the world, close to 6 million right here in the United States, over 55,000 here in Long Island. And it costs an enormous amount of money. Here in the United States, we spend $250 billion to treat these various dementias. And that doesn't include the free care from family and friends and caregivers providing to their loved ones. So let me start off by going through some terms with you. First, dementia, and then mild cognitive impairment. So dementia is a long-term and often gradual decrease in the ability to think and remember. And it becomes great enough that it interferes with a person's ability to carry out their occupational and social activities. It interferes, in other words, with what's called their activities of daily living. Mild cognitive impairment is a little milder in that a person is having difficulty with thinking, possibly remembering, but at this point, it's not interfering dramatically with the person's ability to act in their daily lives. So it's not greatly impacting their activities of daily living. And most people who are affected by mild cognitive impairment or dementia are over 65 years of age, but that doesn't go for everyone. There are people who are struck with these diseases earlier. And they can result from a variety of brain diseases. So dementia is not one disease. Dementia is actually an umbrella term. Both dementia and MCI, mild cognitive impairment, are umbrella terms, by which I mean they can be caused by a variety of brain disorders. The dementia could be due to Alzheimer's disease. It could be due to vascular dementia, which involves strokes, large or small, in the brain. Could be due to dementia with Lewy bodies, which is another form of dementia, or frontotemporal dementia, or some combination. Oftentimes people have a combination of these disorders. And so people can experience a decline in their ability to think for a variety of reasons. Some of them are reversible, and some of them are irreversible, at least at this point. But a number of reversible ones include things like medication side effects, which can impact memory and attention, dehydration, urinary tract infections, hypothyroidism, vitamin B12 deficiency. All of these are things that are reversible with early care. And so it's important that people seek an evaluation if they're experiencing these sorts of problems, so that they can be addressed. Even if it's an irreversible disease like Alzheimer's, there are things that we can do to help treat the person, to treat the symptoms, and to help them and their families. So Alzheimer's disease is the most common form of dementia. It affects 60 to 80% of those who have a neurodegenerative illness in the elderly population. It's an irreversible, progressive, and ultimately a fatal brain disorder. It slowly destroys the ability to think and to carry out even simple tasks over time. It's not a normal part of aging. That said, the chances of getting Alzheimer's disease increase as we get older. So in those from 65 to 74 years of age, the chances are about 3%. But as you get to over 85 years of age, the chances increase to about a third of the population. Now, there are two abnormal structures that appear to be created and appear to be causing some of the problems in Alzheimer's disease. We don't know that for sure, that these are the causes, but they are definitely prime suspects. So there are beta amyloid plaques that form between the nerve cells, and there are tau tangles that are actually formed inside of the cells themselves. And both of them damage and kill the cells, and they destroy communication, and they make the brain process information more inefficiently. One of the things that people often ask is whether Alzheimer's runs in the family. Do you need to be worried if someone in your family has Alzheimer's? And so one of the things I want to point out is that there are different forms of Alzheimer's. Most people who develop Alzheimer's disease develop it after the age of 65. And in that group, there is some transmission, there is some increased chance of getting it if someone in your family gets it. But it's really the early form of Alzheimer's that is far less common, that is the most strongly genetically linked. So there are certain gene mutations, the amyloid precursor protein, presenilin 1, presenilin 2. These are very strongly genetically linked. So the early onset form of Alzheimer's is strongly genetically linked, but the other forms are not nearly as strong. Now, the problem with looking at cognitive decline is that we all think we have it. So this is a survey of folks from New York State, and those who are 45 years old and over, 1 in 9, about 11% of them, feel like their ability to think and remember has decreased, and they're having more problems more often, or they're becoming a little more serious. Now, most of those things are not due to some neurodegenerative illness like Alzheimer's or any other form of dementia. They may be related to normal changes in aging that we will talk about. So it's important to try to distinguish those sorts of things. And so the question, of course, is what's normal aging and what's not, right? And so that's what I want to talk about now. So first, I want to begin by talking about what the brain is doing in the first place, okay? So the brain, more and more scientists are convinced, is what we call a prediction machine. We're always trying to predict what's going on out there in the world that's important to us, and then deal with it, right? We're trying to figure out what's salient, in other words, right here. What's salient or important, and then how to deal with it. And it turns out the brain divides those two things between different portions of the brain. The bottom half of the brain, the cerebral cortex, is most associated with this question of what is out there and what's important. And the top, the dorsal portion, is more involved in how to deal with it, how to act on those things out there in the world in order to behave appropriately. So what happens is that initially those predictions and that knowledge of what's going on out through the world is really pretty primitive, right? So in babies and infants, everything is new. They're surprised by everything that's going on, right? But over time, we we learn what's out there and what's not out there, and everything becomes sort of not as fresh. It's that same old, right? And we develop, as we get older, we have the blessing, hopefully, of developing some wisdom and some expertise, at least in those areas that we have lots of experience with. And that's how we're able to sort of continue living, really, because that's really the bar that's set. Where essentially whatever you've done, however you've been thinking, however you've been working out in your life, you've made it this far. You're not dead yet, right? And so that's really the bar that is set for us. But regardless, we are learning these habits over time, right? And so in normal aging, there are these habits, this crystallized knowledge, and that is less subject to decline as we get older. Our knowledge of the world, that wisdom, it remains. But what does decline is this cognitive flexibility, this ability to respond quickly to new things that we didn't expect, that we didn't plan for, that we have to learn to deal with all over again. That's what becomes a little more difficult as we get older. We're a little less flexible in that way. In order to pay attention, in order to take in that new information, we have to pay attention, right? And so as we get older, our ability to sustain our attention, our ability to focus on one thing when other things are distracting us, those aspects of attention decline. And if we're not paying attention to something, it's difficult for us to learn it. You have to pay attention to it initially in order for you to learn it and to act on it. So if you can't remember something, it could be that you didn't pay attention to it in the first place. As we get older also, we are a little slower and less efficient in learning new information. Kids are like sponges, right? They take it all in. But as we get older, it's a little bit more difficult, and we're a little less efficient at doing that. And it becomes harder for us to sort of spontaneously recall those facts that we would like to come up with, okay? But we are generally able to recognize, with normal aging, we are generally able to recognize, oh yeah, that's the word I was looking for. Oh yeah, that's the name of that person. Oh yeah, right? But we may not be able to spontaneously recall it. So if you look at this graph, you see all these different lines. So down on the bottom, we've got people's ages from 20 all the way down to the 80s. And you see that their scores on many of the tests are kind of going down this slope, right? All the greens and the blues are going down. And those are all those forms of flexible processing, speed of information processing, our attention, which is involved with working memory, and what's termed long-term memory here is really the ability to learn new information and store it in long-term memory. So that becomes a little harder over time. On the other hand, our knowledge of the world, our world knowledge, that remains fairly stable in through our 80s. So that's what we see when we look at folks over time. So as I mentioned, as we grow, we become creatures of habit, right? We regularly repeat the same behaviors when we're faced with the same situations. And about 40% of our time in each day is spent just doing these sort of habitual things, brushing your teeth when you're supposed to, taking a walk, making a coffee, saying hello and goodbye in sort of stereotypical ways, and interacting with the people that we see. A lot of that, it just comes down to habit. Now, what's happened, right? I mentioned this is the coronavirus edition of this talk. The coronavirus has interfered with our habits, right? And that's why it's been so difficult, not only for people who are cognitively vulnerable, but for all of us, because all of us are creatures of habits, and our habits have been thrown off a lot by the coronavirus and continue to be changed as we go through this pandemic. So what's important, right? So here, my slide here from a couple months ago is now out of date, right? So what was really important was toilet paper at one point, right? We couldn't find it anywhere, right? Um, at 6 months ago, a year ago, was anybody wearing masks? Were masks on our radar? No, right? But we have had to change the way that we behave, the way that we interact with other people, and so we have learned new things that are important and new ways to deal with them. I just want to point out that there's a difference between knowing what's important, right, and knowing where to find it, right? Although most of the supermarkets do have toilet paper in stock now, but you also have to go and get it. And so here I'm getting getting a stash of toilet paper from my friend, who then, it turns out, actually developed coronavirus a few weeks later. Unfortunately, he's fine now, but he did go to the hospital. Thank God he's doing okay. This is our brain at work, okay, and our brain under COVID. So how do we distinguish these age-related changes in cognition, or these typical age-related changes in cognition, from what might be signs of Alzheimer's or other forms of dementia? Well, a typical thing is to forget a name, or perhaps forget an appointment even, but remember it later on. But what is less typical is having real difficulty learning any new information, so that if someone tells you something about 10 minutes later, or maybe the next day, you don't remember what they said to you. And it's not due to you're not paying attention initially, although you would have to distinguish that. Sometimes you can't. But it's due to the difficulty in holding on to that new information. And so a typical sign, early sign of Alzheimer's, is asking the same questions over and over again. And that may be because the person doesn't remember asking the question before, or it may be because they just don't remember what answer you gave them before. But an inability or decrease in the ability to hold on to that new information, that is not so typical of normal aging. What's typical in terms of confusion in time is maybe not remembering today is Friday and thinking maybe it's a Thursday. But not knowing that it's winter versus summer, that's a bigger level of confusion. That shows your brain has not been paying attention over the past few months and taking and updating what season we're in. Problems with speaking or writing. So people have different levels of ability with speaking and writing throughout their lives, but when you develop a new problem with speaking or writing, that could be an initial early sign. As we get older, sometimes we have cataracts, sometimes our vision decreases, we may need new glasses. That's typical, but what happens in Alzheimer's and some other forms of dementia is not that they can't see clearly, it's that they don't understand what it is that they see. So they may pass a mirror in the hallway, see their own reflection, but not realize that it's them. That's the type of a visual problem that is more typical of someone with Alzheimer's or with a Lewy body dementia. In terms of decision making and judgment, we all may occasionally make a poor decision, but when you start losing money to telemarketers and internet scams, that's a bigger that's a real call. That's a concern, right? I mean, it's a concern in any case, whether it's due to cognitive decline or not, right? But other changes in judgment could be, paying less attention to grooming and hygiene. That could also be this sign of poor judgment. Could also be a sign, early sign of dementia. So what are other sorts of things? There are some other signs. So some of them appear more like psychiatric problems. People who are depressed or anxious sometimes withdraw from work or social activities. And that can also happen early in the stages of dementia as well. Changes in mood and personality, the ability to control your emotions, or feeling or real apathy, not expressing emotions, not really responding to the things that they used to love to do. Those can all be early signs of dementia. And even if they're not, if they are psychiatric issues, those also deserve some attention. And so it's important to seek help in any case. In terms of misplacing things, look, we all occasionally misplace our keys. I know I have. All right, but once you start finding your keys in the refrigerator, when they're in places they shouldn't be at all, that might be a bigger concern. None of these things all, in and of themselves prove or show that you have a neurodegenerative illness. They're just things that you might want to follow up on. That's all. Okay. Another one might be difficulty completing familiar tasks, like driving to a familiar location, or cooking something that you're very familiar with cooking. Following a recipe that you know really well. Those could all be early signs. So the current treatments that we have for Alzheimer's do not stop or slow down the destruction of the brain cells that are causing the symptoms. What they can do is improve communication between the cells by altering the amounts of chemicals in the brain called neurotransmitters, like acetylcholine or others, but they don't stop the disease itself. There have been a number of clinical trials, treatment studies in the works. They have focused for the most part on beta amyloid and to a lesser degree tau. Those are those abnormal proteins I mentioned earlier on. And the biggest ones have been focused on beta amyloid, and they have been unsuccessful. They haven't been successful to date. However, there is a beta amyloid antibody trial, another one that's looking at beta amyloid, that's in front of the FDA right now. Today, in fact, the FDA is reviewing this application, and so we'll see what happens. If it does get through the FDA, it'll be the first new treatment in a couple of decades for Alzheimer's. It looks as though Alzheimer's, we are going to discover, is multifactorial. That is, it's caused by a number of different things. Chronic inflammation of the brain, we know, is bad. Vascular changes in the blood flow to the brain are bad, and it's it's likely that we will need more than one way to try to treat the disease. I can just mention quickly that we've got a lot of active research going on at Stony Brook. So if anybody is interested, please give us a call. The telephone number is there, 954-2323, or you can find us at cadlongisland.com. There are studies looking at acetylcholine, which is that neurotransmitter important for memory. There are studies looking at estrogen and its impact, the impact of that hormone on Alzheimer's disease. There's studies looking at depression and sex in terms of emotional regulation and negative mood in middle-aged and older adults. There are studies of cognitive decline and its relationship to post-traumatic stress disorder, specifically in people who were World Trade Center responders. And there's a study of Alzheimer's caregivers that's also taking place to look at their health outcomes and their immune function. So all of those, if you contact us, we'll put you in touch with the principal investigators who are running these studies. So none of us want these disorders. And so what can we do to try to prevent them? So I'm going to go through a number of things that we can do that can make a difference, or that can increase our chances. And these are all what we call modifiable lifestyle factors. Okay. One of the things I just want to mention, highlight, we're going to go through a few of them, but one of the things that hasn't received a lot of attention until relatively recently is hearing loss. We don't know why exactly, but people who have poor hearing are more likely to develop Alzheimer's disease and other forms of dementia. We don't know whether it's causing the Alzheimer's disease or somehow they are linked, but it's reason enough to get your hearing checked and to wear hearing aids if it's a problem. So much of the information we get from the world comes through language, right? You're understanding what I say primarily orally through oral language, right? What you hear. And so if people were to treat hearing aids like we treat glasses, you know, and wear them and use them, it might make a big difference. We don't know for sure, but that is a possibility. Smoking, is I'm just going to mention, is also a horrible thing. So if it's possible for you to stop, and please try. You know, smoking is poor for your health in general, but for your brain as well. Okay. So let's go on to some other things that can help you to preserve your cognition. And one of those things is education and cognitive reserve. And what you're doing today, right? You're learning some new information today, hopefully. And so it turns out that people with higher levels of education and occupation and leisure pursuits, that those folks tend to have a delay in the onset of any Alzheimer's symptoms. And so it's good, you know, to engage in lifelong learning, that may benefit you. And you should, you know, as long as you're learning something it is you want to learn, that you're interested in, then you get the added benefit of actually leading a more interesting life. Another thing that I'll point to is sleep disturbance. Just checking my time. Okay. So yes, sleep disturbance. So sleep is really important. And one of the big reasons that people will sometimes have difficulty sleeping is because of disordered breathing while they're asleep, something we call sleep apnea, obstructive sleep apnea, where you stop breathing or you're breathing far less efficiently in your sleep. And that's really bad for your brain. Our brain is just 3 pounds. Okay. It's not very much. It's not a very big percentage when it comes to our total body weight, right? But our brain uses 20 to 25% of our body's energy consumption, the glucose and the oxygen that powers our bodies. About a quarter to a fifth to a quarter of it goes directly to the brain. It is using all that stuff, and it needs it. It needs that oxygen. It needs you to breathe, even if you're asleep. All right. And sleep apnea is treatable, and it's important that you get it treated. Sleep difficulties can also be a sign of depression, which is also a risk factor related in ways that we don't quite understand, but certainly a risk factor for cognitive decline, and depression can be treated as well. Social interaction, you know, so engaging in again, these sorts of social events like this, interacting with your family and friends. I know it's a little more difficult these days, and these days of COVID, but any interaction, even through Zoom, still counts. And there are a number of studies that show that people who have more social connections and engage in regular connections with other people are at reduced risk of developing dementia. I mentioned before that depression is a risk factor. The relationship between depression and dementia is not completely understood. You can have both. You can be depressed and have dementia, or you can have one or the other. And each one is a risk factor for the other. But we do know that treating depression can improve your cognition, because when you're depressed, you're not thinking as well as you usually do. And so if you want to improve someone's cognition, treating their depression can definitely help. So when we talk about prevention, we can talk about these three different things. And we've discussed some of those, some of the aspects from each of those already, but we can talk about, in this blue circle here, cognitive reserve. So education, social interactions, reduced depression, lifelong learning, all of those things increase that brain cognitive reserve. Okay, we can talk about the stuff in the kind of pinkish area on the lower left, involving making sure the brain gets that good supply of nutrients that it needs, that it gets through the bloodstream. So that's why it's so important to treat things like high blood pressure, um, high cholesterol, treat metabolic disorders like diabetes, because all of those things interfere with the brain getting the nutrients it needs, the glucose and the oxygen that it needs. And so if and reducing your chances of having these strokes, and these small strokes can be related to cognitive decline as well, in that vascular dementia that I mentioned. And so treating those things is very important. And then the last thing, on the last sort of general thing, is reducing brain inflammation, this green circle on the lower right. And we know that certain types of diets, like the Mediterranean diet that I'll mention in a few moments, that is one of the things that can reduce your chances of developing a dementia. And there are other things as well that we're going to get into. But what I want to point out is something that's right there in the middle of all of these circles, at the intersection of all of them. You see exercise, right? And exercise is really important. And it's actually the mainstay of trying to prevent cognitive decline in people who have mild cognitive impairment, and even in people who have Alzheimer's itself. There are a number of studies. So this slide here shows all these different studies. I believe there's 19 studies here that have looked at exercise in what we call randomized clinical trials. These are the strongest forms of research clinical trials. Now that they're looking at COVID, they're doing these randomized clinical trials on COVID. Well, they've done them on aerobic exercise in people with mild cognitive impairment and in people who even have Alzheimer's disease. And they find that exercise, aerobic exercise, helps to reduce cognitive decline. People who exercise regularly tend to do better over time in their ability to think and remember. And so, and aerobic exercise is really any kind of activity that gets you breathing a little bit harder, that gets your heart rate pumping a little more. Those all count as aerobic exercise. Walking, dancing, if you play tennis, gardening, going up and down the stairs. So, the next time you realize you forgot something upstairs and you have to go get it, you should think of that as an opportunity to get a little more exercise. Going up and down stairs is really, really good exercise. It's one of the best exercises we have. So I know that it's a little more difficult these days to have at least some forms of exercise, but maybe walking is something that you can continue to do. In addition, online, there are a number of exercise programs. If you YouTube, yoga, or YouTube aerobic workout, or YouTube, chair yoga, you can find all kinds of prepackaged exercise routines that might be appropriate for you. I always tell people, I'm not a physician, so I always tell people to check with their treating physician for exercises that are appropriate. But in almost all cases, physicians are going to be really, really happy that you're exercising. And so if there is any take-home message from today's talk, it is try to exercise. And how much exercise do you need? Well, whatever you do more than whatever you're doing now is good. All right. So whatever you do other than what I'm doing right now, which is sitting down, is good. Anytime you stand up, anytime you walk a little bit, anytime you do any kind of physical activity, all of those things count. So do as much as you can enjoy. A little bit is good and a little more is better. Okay. So the other thing that I want to talk about is the Mediterranean diet. So we know that the Mediterranean diet has some benefits to it. It's very hard to do studies to look at the way that what people eat impacts their health in general, and impacts their brain health as well. In part because it's hard to get people to eat what you want them to eat over a long period of time and then follow them over that long period of time. But there have been some studies that have managed to do that fairly well. And there was a study that looked at the Mediterranean diet in that way. They gave one group of folks nuts and whole grains, and they gave they gave them mixed nuts, right? That's what they gave one group, because that's part of. So I should back up. So the Mediterranean diet, it has a focus on fruits, on vegetables, on nuts and whole grains, a reduction in red meat consumption, and when you're getting your fats, you should use things like olive oil, which are healthier fats in terms of instead of things like butter or lard. You want to use spices to flavor your food, to increase the flavor of your food rather than relying just on salt. You want to eat fish and poultry, at least a couple times a week. But the real focus is on vegetables and nuts and whole grains, beans, legumes, lentils, all that stuff. Those are all good for you. So in this study that they did on the Mediterranean diet, they gave one group mixed nuts. They just gave them a supply of mixed nuts that they could have over a period of a couple of years. And then they gave another group olive oil, a supply of olive oil that they could then use over the course of a few years, and recommended all these other changes, as I mentioned, to the Mediterranean diet. And the other group, they just told them to try to eat healthy, but that was their control group. And it turns out that the group that used the Mediterranean diet, both the mixed nut group and the olive oil group, both of those groups of people did better in their thought processes a year or 2 years down the line than those who didn't. And so that's fairly persuasive evidence for the benefit of this type of diet. This other diet that it's also on that slide is the DASH diet, the dietary approaches to stop hypertension, which is hypertension is high blood pressure. And so reducing sodium, reducing salt is one of the things that can help, I believe sometimes impacts blood pressure. And so that diet tends to follow a lot of the same eating suggestions that the Mediterranean diet does as well. So those are the two diets that have the best evidence to support their use. And these diets also reduce that chronic inflammation. Eating a highly processed foods, highly processed packaged foods all the time, that can sometimes lead to a greater inflammatory response, and that's not good for you. I mentioned this Barcelona diet. It was actually 4 years. I'm sorry, and so this is just a graph showing that the impact there. And there was another study in Finland where they looked at exercise and diet and continued cognitive training and treating those metabolic and vascular risk factors, blood pressure, cholesterol. And they looked at that over a 2-year period, doing all of those things at once. And the group that got that type of treatment over that 2-year period also did better cognitively after a couple of years. So where we appear to be heading in terms of dealing with and treating neurodegenerative illnesses like Alzheimer's is we're looking to develop blood biomarkers in the blood and in brain imaging that can help us identify the very earliest stages of the disease beginning, and then ultimately leading to treatment at those earliest stages, like we do for other chronic diseases, cardiovascular diseases and diabetes, before the disability occurs. Can antipsychotics like olanzapine increase risk of dementia? I am not a prescriber. I have a PhD rather than an MD. So I tend to defer to my physician colleagues to make those kinds of decisions about the use of antipsychotics. Antipsychotics are not FDA approved for the treatment of things like Alzheimer's disease, but they are sometimes used off-label and can be used effectively. And so there are always these risk-benefit analyses that you're trying to make. And so I leave that up to our physicians. We have a number of very good psychiatrists associated with Center of Excellence for Alzheimer's Disease, Dr. Nicole Absar, and Dr. Nikhil Palakar. And so if you're interested in that for a specific person or a specific patient, you'd be welcome to contact us at the CAD, and we can follow up with you specifically for that person. Please feel free to contact us. We're here to help. And this is Alzheimer's Awareness Month, and so this is one of the ways that we are trying to do our part here. And so thanks very much, and take care. Have a good rest of your day and a good weekend.